Thank you again for joining us for Treatment Talks live bladder cancer video chats from the Bladder Cancer Advocacy Network. Treatment Talks are monthly discussions that we schedule featuring a medical expert, and our goals are to help you increase your understanding of existing and new treatments for the spectrum of bladder cancer diagnosis, and also to showcase the patient questions that you can ask to be an empowered patient as you're going through your treatment protocol. We want to highlight some current treatment advances for bladder cancer. We would like to thank our sponsors for the Treatment Talk series, the EMD Serono Pfizer Partnership, Merck, and Urigen for their support of the Treatment Talk series. My name is Stephanie Chisholm, and I'm the Director of Education and Research at the Bladder Cancer Advocacy Network. The immune system detects and protects the body from anything it perceives as foreign. However, cancer's found ways over the years to evade our immune system, and cancer immunotherapy is designed to help our immune system to recognize those cells and to reactivate the specific immune cells that help target and attack them. And while BCG has been around for decades and works as an immunotherapy, there are now a number of new immune checkpoint inhibitors targeting the PD-L1 receptor pathway that have been approved by the FDA for people with types of bladder cancer known as locally advanced or metastatic carcinoma. And that's the focus of today's program. We're delighted to have a leading expert with us today from the University of Chicago, and I'm going to introduce Dr. O'Donnell. He is a specialist in genitourinary malignancies, including prostate, kidney, testicular, but he really does specialize in bladder cancer. Dr. O'Donnell is a well-published researcher with training in pharmacology and pharmacogenomics, the study of the genetic traits that cause differences between patients in drug response and side effects. And I know some of that comes into play as we're talking about these immune therapies. And so we're also joined by two of Dr. O'Donnell's patients, Lynn Sperling and Andrew Kuhns, who I will introduce a little bit later on. Dr. O'Donnell, I'm going to turn it over to you. We know that immunotherapy is not a new therapy, but now it's being used in many different ways. What do you think we should know about immune therapy today?
Thank you, Stephanie. It's really my pleasure to be here today, and I see my charge as setting the stage for really the highlight of this hour, which is, hearing from two people that I've had the privilege of getting to know over many years, and really are the ones that are going through and have gone through treatments like this, Ms. Sperling and Mr. Kuhn. So I'll set the stage, and then we'll move to that portion of the program. Morgan, if you can go forward, I'd appreciate it. I will say at the beginning here that I do work with a number of pharmaceutical companies and entities that have developed or are developing drugs in the bladder cancer space. My institution receives research funding for the clinical trials that helped these drugs get approved. And I am a member of data safety monitoring boards for ongoing clinical trials in bladder cancer. Next slide, please. All right, so I first thought I'd say, but let's get the groundwork of the terminology when we're talking about immunotherapy. Some people refer to these treatments as immunotherapy. Some you might hear the words immune therapy. Some you might hear the word immune checkpoint inhibitor. For our purposes today, they all mean the same thing. These are drugs that modulate or alter a patient's own immune system to fight cancer. Next slide. And there are 4 drugs that are approved for use against bladder cancer that are immunotherapy agents. And I listed those on the slide here. I've listed both the common name or the generic name of these drugs and then the brand name. You might hear your doctor or your treatment provider refer to either. The 4 drugs are atezolizumab, avelumab, nivolumab, and pembrolizumab. All 4 of these drugs are immunotherapies. They're all given as intravenous treatments, IV treatments. They are administered over a portion of about 30 minutes time. And the schedule can be anywhere from as often as every 2 weeks needing to get these infusions to as less frequent as every 6 weeks, depending on which specific drug your physician has chosen and which schedule for that drug they have chosen. Next slide, please. And I want to start here before we talk more about these drugs in depth with a brief portion of a video that I actually recorded with BCAN's help. We're going to watch about a minute of this to understand how immunotherapies actually work in the body. Morgan?
right, that's in your body. Okay, you have the cancer in your body, and then you have the immune cells. Okay, we all have our immune system, so the immune cells are floating around our body. That's how we fight off colds or fight infection. It also turns out that the immune cells can see and detect and try to kill off cancer cells. Okay, when the immune system is working properly, it would actually recognize this as a cancer cell and try to kill and destroy it. The problem is cancers are smart, and so they've developed this ability to put a protein out on the surface of the cancer cell, and that protein makes the cancer cell hide from the immune system. The immune fighting cells can't see the cancer cell when this protein is out on the surface. And so what we do in that case is give you these new drugs called immune therapies. Immune therapies take away this signal here and allow the cancer cell to be recognized again by the immune system. They actually even do more than that. They will rev up and stimulate these immune cells to become active and fight and try to kill these cancer cells.
Wonderful. Thanks, Morgan. If you can go ahead. One slide. Great. So I'm going to say some of that another way because I know that was quick to understand how immunotherapies work. And I think one of the best ways to really put it into context is to describe how immunotherapies are different from traditional chemotherapy treatments, which I think many patients are often familiar with or have at least had family members or friends that might have been treated with chemotherapy. So on the left, we're looking at a representation of how chemotherapies work. And here they're showing that the chemotherapy drug has toxic effects on any cell that it comes into contact with, that being a cancer cell on the left or a healthy cell, any healthy cell in your body. One of the hallmarks that we think about with chemotherapy is that the side effect profile is often difficult or harsh, as is shown on the lower part of the left-hand part of the slide. And then we traditionally don't think about chemotherapies as having longer lasting effects. That is, the post-treatment protection is often of short duration. So chemotherapies traditionally work while they're being given, but that effect will typically stop after the chemotherapy has to be stopped. And what typically happens in almost every patient is that we have to stop chemotherapy at some point because the effects on the healthy tissues accumulate, the side effects accumulate, where we have to pause or stop chemotherapy at some point in almost every patient. Now contrast it against immunotherapies on the right, where, as we're seeing here, the immunotherapies unleash the patient's own immune system to find and kill cancer cells. And so they're actually acting on the patient's own healthy immune cells to use those cells to the body's advantage. And so we think for immunotherapy, unlike chemotherapy, that typically these drugs have a much lower side effect profile, that they're very tolerable in the large majority of patients who receive immunotherapies, a clear advantage to these types of drugs. We also have this very interesting effect of immunotherapies that even in patients who stop immunotherapies, who are not actively continuing to receive those ongoing infusions, we can see that in a number of patients, there will be a post-treatment protection effect. And that's believed to occur because we think that these drugs can actually train the person's own immune system to recognize those cancer cells, and that even when we withdraw the immunotherapy, the immune system remains trained and has a memory to learn how to keep those cancer cells at bay. Next slide. The last thing I'll do to put this into context is to try to compare and contrast a third type of therapy that you might have heard of, and that is targeted therapies, which are on the middle part of the slide. So now we're thinking about differences between chemotherapy, targeted therapies, and immunotherapies. And there are some targeted therapies that are approved for bladder cancer treatment. We don't have time today to focus on those. But if we look at this slide, how do they work? Again, chemotherapy generally targets any rapidly dividing cell in the body. It hopefully has preferential effects against cancer cells, but also clearly damages normal cells in our body. Targeted therapies try to find a specific target on the surface of a cancer cell to then destroy that specific cancer cell because it has the target. And immunotherapies, as we've said, use our own immune system to stimulate the immune cells to identify and treat the cancer, kill the cancer cells. Side effects, again, with chemotherapy, people generally know have lots of different effects that are difficult for patients to tolerate, including hair loss, gastrointestinal effects like diarrhea and nausea, and many other effects on the body's own immune system, for example, where the bone marrow can be damaged by chemotherapies. Targeted therapies can have specific problems related to the specific target. Those can sometimes include liver problems, diarrhea, skin rashes. Again, we won't have time to focus on those today. For immunotherapy, what we'll talk about at the end of this session is that really the side effect that we worry about, and again, it's infrequent in most patients, but that is if the immune system gets revved up too much. If we overactivate the immune system, our own immune cells can start to attack self. That is, they can attack normal tissues in our body like an autoimmune reaction, which many patients are familiar with. The limitations of each of these: for chemotherapy, well, cancer cells can develop a resistance to the chemotherapy, which means that they can start to grow even when the chemotherapy is being given. And as I already mentioned, there's a limitation to the amount of chemotherapy that a person can tolerate in their lifetime because of the damage to normal tissues. For targeted therapy, we also see cancer cells developing resistance. For immunotherapy, resistance can happen, but it perhaps is less likely, especially in patients where immunotherapies are working. It's tailored because it's using the body's own immune system. And one downside is that these therapies are still very expensive to give. Next slide, please. All right, and you might say, well, I've heard about PD-L1. What's that? So how are we talking about immunotherapies without talking about PD-L1? And so I'll draw a connection to something that we saw in the video, which is that protein that's expressed on the surface of tumor cells. And it's actually being shown on this slide. If we look at the right, where we're seeing a collection of tumor cells, they're expressing that protein, which is actually called PD-L1. It's a protein that some tumors can express on the surface. And that expression of PD-L1 engages a receptor on the T cell, which is the immune fighting cell. And that T cell then engages with the PD-L1, and that's what causes the T cell to be turned off. It's what allows the tumor to hide, as we talked about in the video, so that that T cell, that immune system, can't actually see the tumor any longer and can't activate to kill the tumor cell. So PD-L1 ends up being important. It's important in bladder cancer treatment. We don't always have to test for PD-L1 when we're thinking about using immunotherapies, but in general, if your tumor is expressing PD-L1, or if the cells around the tumor are expressing PD-L1, there's a higher likelihood that immunotherapies will work for you. They still can work in patients without PD-L1, and your physician doesn't always need to test for this before they use immunotherapies. There are certain specific scenarios where your physician may need to test for PD-L1 before they can prescribe you an immunotherapy. But in general, we're able to prescribe immunotherapies regardless of PD-L1 status in bladder cancer. Next slide, please. The last thing I'll say about this idea of immune fighting cells getting activated is that we actually know that in a person with bladder cancer, if those immune cells can be turned on, can be revved up, and actually infiltrate into the tumor, so wherever that tumor might be in your body, whether it's in the bladder itself, or if your tumor has unfortunately metastasized or spread somewhere else in the body, that if we did a biopsy of that tissue and took a sample, on the left-hand side, I'm showing a slide of bladder cancer under the microscope where you don't see many immune fighting cells infiltrating into that tumor. The immune cells on this slide would be brown, staining brown. And you can see maybe just one or two of those cells infiltrating into this patient's cancer. We call that a low number of immune cells, sometimes called killer T cells. Low number on the left. On the right, we see a large number of these brown staining cells, which are the immune fighting cells infiltrating into the bladder cancer sample. And what's been shown in many instances in elegant work is that if your cancer has infiltration of these immune fighting cells, your outcomes are much likely to be better from a bladder cancer standpoint. You're likely to respond to immunotherapies better, and you're likely to live longer. Next slide. The last thing I'll say is, where do we think about using immunotherapies? And maybe this will be a great topic for the question and answer portion, is thinking about, well, when would your doctor actually think about using an immunotherapy? There's three main settings right now in 2021 where immunotherapies have a role for the treatment of bladder cancer according to FDA approvals. The first treatment setting is one that patients may not know as much about. It's more recent. It's happened only in the last couple of years. And that is actually for patients after BCG treatment, before the bladder has actually needed to be removed. Specifically patients, as I'm showing on the left-hand part of this slide, that have tumors that are earlier, that are not as far as advanced. You can see some of those tumors are described T2 or T3 or T4. These are more advanced tumors that have invaded into at least the muscle or deeper layers of the bladder. Those patients right now, we don't think about using immunotherapies. Those patients need their bladder removed, and they probably need chemotherapy as well. For patients that have lower stage disease, you can see on this slide T1 or CIS, which means carcinoma in situ. If you have those features, you may be eligible to think about using immunotherapy, a drug specifically called pembrolizumab, which I mentioned at the beginning, one of the 4 immune therapies that's approved. Pembrolizumab may be an option for you if BCG is no longer working. And it may allow us to decrease that tumor, keep it from coming back in the bladder, and delay the need for your bladder being removed. That's a less common instance of how we use immunotherapies, at least right now. More commonly, we use these immunotherapies when, unfortunately, the cancer has already spread outside the bladder, as I'm showing on the diagram on the right. And many patients know that bladder cancer can spread basically anywhere in the body. Common locations where bladder cancer can spread is into lymph nodes, into the liver, into the lung, even into the bone. And so there are options where if your cancer has spread, to use immunotherapy as the first treatment that you would receive for metastatic bladder cancer. In specific instances, we will think about using immunotherapies as the first-line treatment if, for example, a patient cannot tolerate traditional chemotherapy. Chemotherapy is usually the first choice for most oncologists if you have metastatic bladder cancer, but a small portion of patients might be able to be spared chemotherapy altogether and receive immunotherapy as the frontline treatment. Those patients, again, have some reason why they can't receive chemotherapy, and those patients need to have high PD-L1 status, as we talked about earlier. The more common reason is the third one that I'm listing on the slide at the far right, which is that if you've already had metastatic spread of your bladder cancer, you receive that frontline chemotherapy, there's now a role for using immunotherapy after chemotherapy in one of 2 different ways. One is that your doctor can go ahead and, as soon as you're done with that initial chemotherapy, transition you or switch you straight into what we call maintenance immunotherapy. And this is something that's new over just the past year in bladder cancer. A large study was published in the past year that showed that patients who come off of their frontline chemotherapy and go straight into a maintenance immunotherapy approach live longer than patients who just get chemotherapy alone and then are followed. So the idea of maintenance immunotherapy, which has specific evidence around the drug avelumab, which I mentioned earlier, is now becoming adopted widely in the treatment of bladder cancer. So if you haven't heard about this, you should ask your doctor about whether there's a role for maintenance immunotherapy for you. The last option, as is said in item number 3 on this slide, is that some patients will go through frontline chemotherapy and then they will choose to be followed, that is, to watch their cancer after the initial chemotherapy has worked. Typically, doctors will adopt a period of regular scans that'll be done every 3 to 6 months. And then if one of those scans should unfortunately show that your cancer is growing again, we don't typically go back to the chemotherapy. That's when we would go to immunotherapy as a second-line treatment after chemotherapy has stopped working. These are very common instances where immunotherapies are given. Next slide, please, Morgan. All right, and this is my second to last slide, which is that we do have to acknowledge that just like any therapy in medicine, any medicine that you would take certainly can have side effects. I already said that compared to chemotherapy, immunotherapies are much more well tolerated in general for bladder cancer patients. I tell my patients that probably about 9 out of 10 patients that get immunotherapy are going to feel generally well. They're going to actually say, "Doc, I see the bag hanging up there, but I don't feel like I have any side effects from the therapy." 1 out of 10 patients will have a more serious reaction in the body to the immunotherapy, and that is sometimes what we call an itis. You can see that a lot of the words ending on this slide end in itis, which means an inflammation of a specific organ in the body. The most common inflammation that we see is on the skin, which is that patients can get a rash or itching or discoloration of areas of the skin. These are the most common type of immune-related side effect. Most patients, these are minimal and tolerable and can be treated with even topical treatments. In other instances where we see more severe reactions against the immunotherapy, this gets to what I was saying earlier about an autoimmune-like reaction, where your body's immune system has revved up so much that now your own immune system is attacking a critical organ. It can attack the lungs, the liver, the gut, even the heart or the nervous system. These are serious events, and these patients often need to be hospitalized for high-dose steroids to calm down the immune response. The good news is that in many cases, that inflammation, that itis, can be reversed with the use of steroids. The question really is then whether a patient can ever go back to immunotherapy if your body has had one of these very high stimulation of the immune system adverse events. And that's a discussion that you would have with your doctor. But again, in general, compared to chemotherapy, I can tell you that my patients would choose immunotherapy every day of the week from a side effect profile. Next slide, please. So in summary, immune therapies have really revolutionized the treatment of bladder cancer. All of these immunotherapies were approved within the last 5 years, and so we've seen a dramatic change in how we can approach the treatment of bladder cancer and a huge increase in the number of tools that physicians have to combat this terrible disease. These therapies have clearly increased patients' chances for survival, even patients with metastatic disease. They work differently than chemotherapy, they're generally well tolerated, and they are options in multiple different settings of bladder cancer. So I'm going to stop here, and Stephanie, I think we're going to transition to Mr. Coons and Ms. Sperling.